Hello, my name is Nat Soper, and I'm going to be speaking today about acute cholecystitis, things about the disease itself, a severity assessment, and classification of the severity, as well as the appropriate treatment for this disorder. So acute calculous cholecystitis is acute inflammation of the gallbladder caused by stone or sludge blocking the outflow of the gallbladder, either its neck or the cystic duct. It usually results in abdominal pain. It can be right upper quadrant or epigastric, and there can be radiation, and it's caused by an elevated intragallbladder pressure. This is usually severe pain, and it can be associated with nausea, vomiting, fever and chills, and mild jaundice. And the patients are usually tender in the right upper quadrant with a positive Murphy sign. So the Tokyo classification has been around since at least 2013. It's been updated once in 2018. And the diagnostic criteria to make the diagnosis of acute cholecystitis include local signs of inflammation, like Murphy sign or right upper quadrant mass or tenderness, systemic signs of inflammation, which can be fever or elevated CRP or white blood count, and or imaging findings of gallbladder disease, such as ultrasound or MRCP. A suspected diagnosis would be made if there is one item in A and one item in B, and the definitive diagnosis would be if there is one in A as well as one item in both B and C. And in terms of the classification of the severity, grade 1 is mild acute cholecystitis. This is a healthy patient without organ dysfunction and mild inflammation. Grade 2, which is moderate acute cholecystitis, usually is associated with an elevated white blood cell count, the palpable tenderness in the right upper quadrant or a mass, duration more than 3 days, with marked local inflammation on imaging, like a thickened gallbladder wall or pericholecystic fluid. Grade 3 is severe acute cholecystitis, and it's a grade 2 associated with organ dysfunction, and it can be many different organ systems that are dysfunctional, and these patients can actually be very sick. And the relationship between the severity and the outcomes are stark. So 30-day mortality with a grade 1 is 1%, and it goes up to about 5% with a grade 3. Length of stay goes from 4 days to 10 days. The conversion from laparoscopic to open rate goes from 5% to 20%, and the rate of morbidity goes from 5% to 30%. So certainly the grading is very important in looking at the prognosis of acute cholecystitis. So most of the time, these patients are treated by laparoscopic cholecystectomy for definitive treatment. Now, this has been around now for about 3 decades, and this just shows the historical progression of this operation. You know, in 1991, there was a publication of 1,500 lap choles. I was involved in an NIH consensus conference in 1992 that suggested that laparoscopic cholecystectomy was appropriate when performed by people who were well trained. It wasn't until 1992 that the first randomized prospective studies of laparoscopic versus open cholecystectomy were published. And it wasn't until 1998, or 10 years after the introduction of lap chole, that there was the first randomized controlled trial of open versus lap chole for acute cholecystitis. And this was at the same time that there was a lot of lay press about this operation, and doctors scrambled to learn it. That was one of the key things back in the early 1990s. The initial outcome studies were done, and they virtually all showed the benefit of laparoscopic to open cholecystectomy, but there was problems raised with the possibility of bile duct injuries, particularly early in a surgeon's experience. And it was worried that in the presence of severe acute cholecystitis, it might increase the risk of these bile duct injuries. And this shows that learning curve from the Southern Surgeons Club. Now, the randomized trials were in 92 and in 93, 94, and it showed that the operating time at that time for open cholecystectomy was faster, but everything else was better for lap chole. Shorter length of stay, faster return to work, less pain, etc. and the complication rate, et cetera, was about the same. We were concerned, though, that laparoscopy was image-based and the acute inflammation can clearly distort the anatomy. And there were several early studies suggesting that the risk of bile duct injury was higher with acute cholecystitis than with chronic cholecystitis. And so we all said and stated that lap chole for acute cholecystitis should be performed by experienced surgeons. And back in the day, we said maintaining a low threshold for conversion. What about lap chole for acute cholecystitis? Well, the first randomized trial was in 1998 by Kiviluoto, and there was a fairly high conversion rate of laparoscopic to open cholecystectomy. The complication rate, though, was 1/10 that of open cholecystectomy. The length of stay was 4 days versus 6 days, and the sick leave was half that for lap chole compared to the open cholecystectomy. And early on, again, we were concerned about the possibility of causing harm by performing lap chole in the presence of acute cholecystitis. So early in our experience, there was a fairly low threshold for performing percutaneous cholecystostomy to try and cool patients off. Now, most of the time, this is usually only done for patients thought to be unsafe for general endotracheal anesthesia. And it's been shown that after percutaneous cholecystostomy, early lap chole has similar results than later lap chole or delayed lap chole. If one performs percutaneous cholecystostomy early in the progression of acute cholecystitis, there were fewer adhesions and a lower conversion rate than if you waited until the disease was well underway before performing percutaneous cholecystostomy. A newer approach, and there's not much literature on this, is an endoscopic cholecystostomy. There's been at least one trial comparing this with percutaneous, showing fewer complications and re-interventions than with percutaneous cholecystostomy. More to come on this technique in the future, I believe. So what about lap chole and acute cholecystitis? There were 2 prospective randomized trials in the late 90s from Hong Kong, both showing a superiority of early versus delayed lap chole, with higher conversion and complication rate when delayed more than 3 to 7 days after the initiation of acute cholecystitis. And the length of stay was longer and the recuperation rate was longer. So it was thought that early cholecystectomy is better than late. Well, more recently, there was a meta-analysis performed by Lau with 4 trials and 500 patients. There was slightly less conversion in early cholecystectomy. The length of the operating time was equivalent. Complications were equivalent in the 2 groups, but the length of stay was significantly less when performing cholecystectomy early in acute cholecystitis rather than later in the hospital course. So what do the Tokyo guidelines tell us about the management of acute cholecystitis? Well, in patients who have mild grade 1 acute cholecystitis, it's thought that they should be given a dose of antibiotics and hydration, et cetera, general supportive care. And then the vast majority of these patients can be treated by early laparoscopic cholecystectomy. For those with grade 2 or moderate acute cholecystitis, again, antibiotics and general supportive care. And in those patients who are in a location where there are good experienced surgeons present, urgent or early lap chole is probably the way to go. Whereas those patients who are at high risk or fail early conservative treatment, consider early gallbladder drainage with delayed or elective laparoscopic cholecystectomy. And finally, for those patients with severe or grade 3 acute cholecystitis, again, these are patients who have some degree of organ failure. So again, antibiotics, general organ support. If patients have no negative predictive factors and favorable organ system failure, that is relatively rapidly improving, and you're an advanced center with good surgeons, early lap chole should be, again, the standard of care for these. But the patients who have severe organ system dysfunction, or very poor performance status, they are the ones who are the best suited to an urgent or early gallbladder drainage, either percutaneously or endoscopically. In those patients who have good performance status, then go on to a laparoscopic cholecystectomy, whereas those who are extremely ill may never go on to a cholecystectomy, but be observed for other factors. So I would say in conclusion then, that the definition and classification of acute cholecystitis severity and management algorithms formulated by the Tokyo classification in 2013 and 2018 should really guide us in the management of acute cholecystitis in the year 2021. For the vast majority of patients, early laparoscopic cholecystectomy is recommended, especially for those with grade 1 and grade 2 acute cholecystitis. Those patients with severe acute cholecystitis and some measure of organ dysfunction, those who are grade 3 by the definition system, should be managed operatively by experienced surgeons, or those patients who are really ill should undergo cholecystostomy, especially when they are unstable. And subsequent cholecystectomy will be dictated by the condition of the patient, him or herself. So thank you very much for your attention today. I'm very happy to have been involved in this recording. Thank you.